Welcome to OneMedicine. In this video, we'll be talking about refeeding syndrome. So, refeeding syndrome is a potentially life-threatening shift in fluids as well as electrolytes. This usually happens in a patient who is chronically malnourished and is being refed after a period of starvation, usually for more than 10 days. It can occur in patients who are being fed with both parenteral as well as enteral route. Let's understand how refeeding syndrome happens. So, in a patient who is chronically malnourished and who is starving usually for more than 10 to 12 days, if the patient is instilled with a carbohydrate load both orally as well as parenterally, this will lead to an insulin secretion. When there is rapid insulin secretion, it will lead to intracellular uptake of glucose, but along with that, it will also lead to intracellular uptake of potassium, phosphorus, and water, and several other electrolytes. This leads to the classical triad of refeeding syndrome, which is known as hypophosphatemia, hypokalemia, and hypomagnesemia. Clinical features can be broadly classified into cardiac, metabolic, musculoskeletal, as well as neurological. The cardiac clinical features include arrhythmias, potentially due to hypocalcemia, hypokalemia, as well as hypomagnesemia, hypotension, primarily due to extravasation of fluids, cardiac failure, can be due to vitamin B1 deficiency in chronic alcoholic patients, which accelerates the or worsens the cardiac failure. It can also be due to hypokalemia, leading to reduced cardiac activity. Patients can also come with edema due to third spacing of fluids. Metabolic includes anemia. This is mainly owing to the chronic malnourished state of the patient. Along with that, patient can come with uremia, hypokalemia, hypophosphatemia, hypomagnesemia, and several vitamin deficiencies, especially the water-soluble vitamin deficiencies. Musculoskeletals include paresthesias, weakness, and fasciculations, primarily due to hypokalemia and hypomagnesemia. Neurologically, patients may be delirious, may throw up seizures, may be ataxic, possibly due to B1 deficiency as well. Wernicke's encephalopathy needs to be picked up early as it can be life-threatening in the patient. So how do we assess the risk of developing refeeding syndrome? So the patients who are chronically malnourished, especially for more than 10 days, are at a very high risk for developing refeeding syndrome. Apart from that, patients with a baseline BMI of less than 16 kg per meter square, a patient with unintentional weight loss of more than 15% in 3 to 6 months, low levels of electrolytes before feeding itself, of course, can lead to worsening of the levels of electrolytes, including magnesium, potassium, as well as phosphorus, and previous history of alcohol usage can be leading to both vitamin deficiencies as well as inadequate response in carbohydrate metabolism and worsening of encephalopathy. So, what are the preventive steps that we use to avoid development of refeeding syndrome in high risk patients? So, the first and most important treatment or preventive strategy is slow and steady nutrition replacement. So, as soon as the patient comes and after you have assessed that the patient has been starving for more than 10 days with little or no nutrition, the patient needs to be admitted in the hospital, and the nutritional replacement should start very slowly, such as 10 kilocalorie per kg per day, and it can slowly be increased to 100% needs over the next 4 to 7 days. Fluid resuscitation needs to be done in patients who are especially in shock due to dehydration. Oral and parenteral vitamin supplementations are really beneficial in reversing the vitamin deficiencies and also leads to reversal of Wernicke's if it is present. Close monitoring of the electrolytes is of utmost importance here, and electrolytes need to be repeated every 8th hourly or 12th hourly to look at any possible hypokalemia, hypomagnesemia, and hypocalcemias.